Luminary presents Therapy versus the World. I'm your host, Joe Nucci, and today I'm very, very excited to share this conversation I had with Professor Nicholas Haslam. Professor Haslam is a professor of psychology at the University of Melbourne. He's the author of 11 books and over 300 journal articles. Out of all of his academic focuses, one of them is particularly important to me, and I'm guessing to you as well. He studies something called concept creep. He's going to tell you a little bit more about it, but concept creep is this phenomenon in which harm-related terms, their definition expands over time. So for any of you who care about mental health, psychology, culture, even politics, this is a really, really important episode to listen to. I learned a lot, and I know you will too. And if you've been enjoying this podcast, please, please, please like, subscribe, and rate this podcast on however you get your podcasts. I know we would really, really appreciate it. Welcome, Dr. Haslam, or do you prefer to go by Nick?
Nick is good. Thanks so much for the invitation, Joe.
Yeah. Well, Nick, like I said, I am genuinely just so excited to talk to you because even before I discovered your research and a lot of your writing, as it turns out, I had been asking myself some of these same questions more from the cultural kind of media side of things. And so I'm very, very eager and excited to talk to someone who's been doing research on this. It looks like you published your first paper about concept creep in 2016. I'd love to know a little bit about what was going on then. What were you observing? Even, at this point, that's almost 10 years ago. What was happening? How did you come upon this concept? And for those who don't know, please explain what it is.
Sure. So what was going on? I was getting older. And as you get older, I think you think back on your career and you have witnessed your field evolve. And you notice when things change. So I guess at that point I was in my early 50s. I'd been doing this game roughly 30 years. I got my PhD in 1992. And I was just seeing words I thought changed their meanings. And it started off, I was looking at concepts of mental illness and then concept of trauma and concepts of bullying. And I was thinking that all of these concepts were sort of moving in the same direction, namely broadening their meanings. So they initially had a fairly narrow meaning, and it seemed that over the decades they'd acquired broader meanings, more extensive meanings, and that's what concept creep is. I define it as the gradual expanding or inflation of the meaning of harm-related concepts having to do with suffering or damage or bad behavior. And I wrote this paper, came out in 2016. Got quite a lot of media attention at the time. There was a nice piece on it in The Atlantic. Got a whole lot more attention in your country than mine. I'm based here in Australia, so maybe it's better known over there. That's sort of the personal history bit. I guess it was kind of a passion project for me. I'd been doing a lot of fairly grim work on the psychology of dehumanization, which has been my main research area for almost 20 years now. But as I said, I was just noticing that people were using words differently, and I thought maybe it's time to try to integrate that and say something a little bit controversial about it.
And what was controversial about it for people who are just kind of understanding this concept from your perspective for the first time? It's not necessarily obvious to me, at least from a first glance, of why it would be considered controversial. I think a lot of people understand instinctively how words like anxiety and depression have a clinical meaning, and over time people use them synonymously to mean sad or low mood, or that they're feeling anticipatory or nervous. That's a very accessible example, but when you published this, there was some controversy. Can you explain what it was and if you think it was fair?
Look, I think you've really hit the nail on the head there. It isn't really such a surprising idea when you're talking about mental health related concepts, because I think a lot of us are aware that diagnostic concepts, for instance, have come to be used a bit more extensively, or maybe loosely is another way of putting it. That's not so surprising, and that's not really where I think the controversy came in. And by controversy, I don't mean a huge yelling and screaming. I just mean that people disagreed with me, which of course they should never do. The controversy really came around more to do with points about the expansion of ideas like prejudice and bullying. I was making this argument that it's not just mental illness-related concepts that are broadened, but a whole range of concepts to do with the way in which we treat people badly. And I was saying that you could witness this in broadening definitions of prejudice to include ideas like microaggression, or in the way in which bullying was being expanded to refer to different sorts of behaviour. And of course, when you wade into this sort of terrain, people think you're joining the culture wars and that you're a nasty reactionary, because you're invalidating people's experience when you say that maybe these concepts are broadening. And I thought I'd gone to great pains to be neutral about this and just to say this is happening, what its implications might be, what the implications of broadened concepts of bullying or prejudice or trauma might be. That awaits to be seen, but I'm primarily documenting that this change is occurring. But I think people thought that by raising this as a apparent historical fact that concepts were changing their meanings, I was somehow criticising that change. And I really think I wasn't. So I found some of the criticism a little bit over the top and unfair, and kind of slotting me into this culture warrior identity I didn't have and still don't have. So that's sort of where it came from. It was surprising at the time. I wrote this piece for a journal, which is a terrific journal called Psychological Inquiry, which solicits feedback from colleagues. They can write little commentaries on your pieces. And basically everyone my age or over, with one exception, loved the piece and thought I was onto something important, and pretty much everyone younger than me hated it and thought I was on the wrong side of history. So that was a surprise to me. Not that I expected universal praise, but the fact that it was politicized as much as it was surprising.
Could you talk a little bit about, in the definition of concept creep, how do you distinguish between a concept scope creeping, or I know it's sometimes used interchangeably with the term harm inflation, if I'm understanding correctly. So there's the phenomenon that you're describing and observing and trying to study and measure, and then there's also just misusing a term, a clinical term. Could you talk a little bit about, I mean, maybe there's not a difference, but I'd be curious to know, because as someone who is maybe a little bit more involved in conversations about this on the kind of the culture war front, it's not always clear to me what we're actually talking about. Are we talking about the expansion of the scope, of an accepted scope, or are we actually just now using it to mean something completely different? And I realize that there may not be a super definite answer, but I would love to hear your thoughts on how to go about sifting through all that confusion.
Well, I'm going to disappoint you because I don't have a super clear answer. But look, if people are using words in incorrect ways, that is an expansion. I mean, that's still creep by my definition. If people are using a word where it doesn't belong, in addition to where it does belong, that's why it's expanding. It's not just shifting from one meaning to another. It's retaining its original meaning. There are still genuine narcissists, but then there's also narcissism applied just to everyday arrogance, for instance. So that's a misuse of the concept from the standpoint of the original narrow meaning, but it's a broadening of the scope. Again, there's an ambiguity here, because you could talk about is the meaning at a cultural level, at a shared level broadening, or is it just broadening with certain individuals using words wrongly? But I think, we find that there are huge differences between people in how broadly they use harm-related terms. And by the way, the same people who have broad concepts of mental illness also have broad concepts of bullying and trauma and all of these other things. These things go together. So I'm sort of going off on tangents here, I'm sorry, Joe, but there's no simple answer. But I think harm inflation or concept creep just refers to more expansive use of certain words.
When you say that people with broad concepts of something mental health related, were you saying that, and correct me if I misunderstood, but are you saying that people that prefer a broader concept in this category are likely to prefer a broader concept in another category?
Absolutely. Yeah, we find that again and again. We've tried to measure this in one of the lines of research that my colleagues and I do. And essentially what we do is we present people with examples of things which might or might not be bullying or trauma or mental illness or whatever else. You give people marginal examples and you ask, do you think this is an example of bullying or trauma or whatever else? And some people just have lower thresholds for this than others. And if you have a lower threshold for bullying, if you're more likely to see more sorts of bad behaviour as bullying, you're also more likely to see marginal adversities as traumas. You're more likely to see everyday misery as mental illness, and so on. I think there's a general tendency to be more vigilant for or more alert to, or have just a broader understanding of what harm is. So yeah, it's across the board.
Have you, because I know you've done a lot of great work in the personality domain, if I'm not mistaken. Do you know, has there been any like big five or five-factor model correlations between, I guess, tolerating the broad end of a definition versus not? Because if I'm making something up as someone who's a little fluent in that literature, I could imagine someone who's low in trait orderliness, it doesn't really care about the minute definitions between different words versus, or maybe even someone who's high in trait openness could like the evolution and like the gray area. But then I'm also thinking just something like trait agreeableness. You know, if someone is going to misuse a word, I'm going to be less likely to push back or have an opinion because that would make me uncomfortable. And then there's the whole neuroticism conversation as well. Are people who are more sensitive to negative emotion going to like a broader concept? Is there anything in the data that suggests any kind of correlations to just temperament?
Yeah, there certainly is. So what we find is, generally speaking, not looking narrowly at just concepts to do with mental ill health, but looking generally at harm-related concepts, people who are higher in agreeableness tend to have broader concepts. I don't think it's just because they go along with other people just out of being diplomatic. It's they just care for people more on average. And look, I think we do want to acknowledge that people who have broader concepts of harm generally do so because they want to protect people, want to look after people, are empathic. You find more empathic people, which of course goes along with being high in agreeableness, having broader concepts of harm on average. But it's not just agreeableness. We also find that one facet of neuroticism called vulnerability tends to correlate with it as well. So people who are somewhat more, feeling on average somewhat more personally vulnerable, personally at risk, are also more likely to have broader concepts. So, you've kind of got these two narratives going on here. On one hand, is it the case that people with broad concepts of harm who see more things as harmful, are they just sort of really sort of loving, empathic, good-natured people who are concerned for others, or are they melting snowflakes? And the evidence tilts more towards the empathy story than the snowflake story, but there is some admittedly quite weak relationship as well between being somewhat more personally vulnerable and having a lower threshold for perceiving harm.
Do you know?
Sorry to interrupt there, Joe. But I mean, one thing that goes with this as well is it is politicized. So people who are more on the sort of liberal end of the political spectrum also tend to have broader concept of harm across the board.
Well, what's interesting about that is my knowledge of the personality literature and the political differences is it's really around openness and orderliness, but you're saying that this split, there's something around vulnerability and neuroticism, but it's really more around agreeableness. I'm not aware of any literature suggesting that the more left-leaning or liberal types are more compassionate, although that would be the stereotype, that they score higher in trait compassion. Do you know if that's been reflected just from a more of a cultural framework? Are people who identify as more left-leaning typically higher in trait compassion?
I actually don't know well enough that literature. I think, as you say, I think part of the stereotype is that people on the left-hand side of politics are sort of compassionate bleeding hearts. That's the stereotype, at least. How much truth there is, I don't know. And I'm not saying that the political ideology connection to holding broad concepts is reducible to agreeableness. I'm just saying it's yet another thing that distinguishes people who hold broad concepts from those who don't. So it might be completely unrelated to agreeableness. It might just be something to do with having more concern with avoiding harm to others. I mean, the work on the moral foundations theory by Jonathan Haidt and colleagues, for instance, does show that people who are on the liberal end of the spectrum tend to have a harm-based morality more than others. So it makes sense that they would be more alert to harm and maybe see more things as harmful. And that may not be about being more compassionate or agreeableness or agreeable.
Definitely. Well, one of the things that I've really liked about your work and the media appearances I've seen you in is I actually think you are, and I mean this as a compliment, a complete textbook researcher. You really toe that line of talking about what the data says and not necessarily misapplying it to different political or cultural phenomenon or debate. One of the things that I have found, so and for those who are listening that don't know, and for you in case you don't know, I didn't plan on becoming a figurehead in this conversation. It was one of my earlier videos. It's still up there pinned at the top of my page at around 6 million views. And for context, when you have I think I probably had less than 20 or 30,000 followers at the time. So that's quite that's really engaging in terms of piece of content. And I make this video and I say something about I'm so over this cult of trauma is what I term them. And I said, these are people I'm seeing on social media who are assigning everything a trauma response. And the issue with that is, well, you don't have to think. Is it something else? Is it chemical or biological? Does it have a different, we would call it an etiology, an origin, if we're going to use the medical terminology? And I had no idea that it was going to spark quite the debate. I mean, something like tens of thousands of comments later. And I remember being not completely surprised, but there was a little bit of astonishment for me because I wasn't coming from a political place, at least not consciously. Of course, my own philosophies definitely play a role, but I remember looking in the comments when it was a fresh post and seeing how political people were making it, kind of like you. And I was like, oh, this is actually really interesting. I was coming from the perspective of, oh, well, we need to be careful what kind of stories we tell about our pasts, especially when it comes to something like trauma. I had a great conversation with another content creator, Matthias Barker. He comes from a different school of thought from me. He thinks that we can categorize pretty much anything that's a trauma that has that results in some sort of maladaptive pattern or response. For him, that's enough for it to be constituted as a trauma. And I was talking to him about that a little bit, and I brought up this book, what's it called? Mistakes Were Made, but Not by Me. Are you familiar with this one? And I was just kind of thinking about our fields. And so as someone who not just does research in the field, but is obviously, I'd be curious to know your knowledge of the history, particularly around terms, because there does seem to be something around popular psychology terms in which things kind of catch on and maybe they expand, and then people are like, oh, well, this doesn't really seem like that legit of a concept anymore. And then we just kind of forget about it. Most people don't necessarily remember the satanic panic or the repressed memory kind of, I don't know if mass neurosis is quite fair of a way to put it from decades ago, but it's a part of my field's history that I'm certainly aware of. And I'm wondering, do you think that concept creep is at play then as well, or is it kind of a newer phenomenon only for the 21st century?
Oh, look, concepts have always changed. No one's trying to hold back concepts. It's like trying to hold back the tides. Ideas are always evolving. So I'm not at all saying that this is something that's unique to the present. We do tend to focus on the changes that have been occurring over the last 4 or 5 decades in our research, primarily just because that's where we have data. We don't have data going back further. But look, if you want to take the prehistory of trauma as a concept, I wrote about that recently in a journal article, which certainly didn't get 6 million views. Trauma until the beginning of the 20th century was a physical wound. It wasn't referred to a psychological wound at all. That was a concept creep. That was a metaphorical extension from one kind of wound to another kind of wound. So trauma was now referring to both physical and psychological wounds. So there's a concept creep happening 120 years ago. But it's undergone, as you say, a whole range of broadening since then. Broadened, in terms of what counts as a traumatic event, from being only these sort of life-threatening, outside the range of normal human experiences, as DSM-3 put it, into experiences that could be vicarious, indirect, developmentally inappropriate rather than life-threatening. And then, of course, people take it further and talk about collective trauma or intergenerational trauma, and little t and small and big T trauma. All of these ways of expanding the concept have been going on at a frenzied pace, I think. And how I see it is partly when concepts become popular, they start to acquire new meanings because ideas which are good to think with, people will apply them in new ways. And the nature of psychological reality is that everything's on a continuum. There are no true categories. There's no real definition of trauma out there waiting for us to find it, like some sort of chemical element. There is no essence of trauma. So the more attention we pay to something culturally, the broader the concept will grow. And look, putting on my researcher hat, the only one I really have, as you say, we actually show this. We show that as the more a word gets used, the more its meaning broadens. We show that using very fancy economical statistics. So I think just the more people talk about something, the more promiscuously the meaning expands.
So there's good reason to believe as mental health not just becomes less stigmatized, but I would argue, at least in the West, it's become almost popularized in a way as a topic. We can actually expect not just the potential for misuse or misapplication, whatever that might be, but also the more broadening, the more of the concept creep.
Absolutely, and we're seeing it. I mean, again, a student of mine's just done a study on this. The word mental health, the word mental illness, they are used more and more. They appear, they're much more salient. We're just saturated with that in our everyday and social media these days. And we should therefore expect more and more things to count as mental ill health. More and more things will be sucked into this vortex of mental health, which previously weren't, just through more attention being paid to them. So I think this is going on at a rapid rate. We are defining more and more things as being mental health related, more and more things as being mental disorders or illnesses or problems. We're sort of witnessing a pathologization of ordinary life, which is paradoxically caused by the normalizing of mental health and the destigmatizing of mental ill health, as you say, which is a great thing, right? It is good that people are not as shamed as they were at an earlier time and are seeking more help for it. But we shouldn't be surprised if that also has a downside, if that also has some sort of ill effects, if people start prizing disorder-based identities, or if people start seeking treatment that they don't really need, or if they start feeling permanently damaged by things which previously would have just been seen as everyday slings and arrows.
Something that I've said to different commenters, because I wasn't really tracking the popular usage of a lot of these terms, and so I started making content, and sometimes I was concerned, sometimes I like the way something has been broadened, and not a piece of rhetoric, what word am I looking for? A counter argument to me, I often hear, is, Joe, the cat's out of the bag. This is already being misused, and if enough people are using it, it is technically, at least from a linguistic perspective, an acceptable definition or an acceptable usage, and this is where we're at. And I want to know what you think to my response to that. What I often say to these people is I say, listen, I'm not saying that everyone has to agree with me. I had a lovely conversation with another colleague I mentioned, Matthias, where we don't actually philosophically see the same concerns about the broadening of the word trauma. I don't expect everyone to agree with me. I don't expect every therapist to agree with me. I do want people to know that there are different perspectives about this and that there are different implications. And I don't actually think that's a lot to ask, because if you look at other subcultures, people who like talking about the law or people who like talking about physical health, we know that there are competing schools of thought around how to interpret common law around vaccines, around different things, and you can think that one side is crazy and one side is enlightened, or some combination of the two, but at least people know that there's a debate. And so one way I've understood my position is by saying, look, I'm saying this not because I want everyone to agree with me or I'm right and everyone else is wrong, but I do think it's important as we start discussing mental health more that you understand that there is a deep debate in our field around the medicalization of everyday life, and how much of it can you really encode in this, and how much of that is okay and how much of it's not okay. And unfortunately, and correct me if I'm wrong, but I don't think we actually have a lot of data to guide those more moral philosophical questions. It really does come down to differences in politics and philosophy and temperament.
Yeah, look, I couldn't agree more. I think it's really important just to teach the conflicts, as they say, and to represent the idea that there could be a downside to all of this. And yes, the cat may be out of the bag, and one researcher, in distant Australia and or one highly successful podcaster probably can't stem the tide. But it's really important to represent the fact that, as you say, there are different views on this. And I think, it's important, especially because not many people are saying this. I think a lot of people are noticing it, but not many people are criticizing it, partly because criticizing this expansion of perceived harm and this expansion of the pathologization or medicalization, whatever you want to call it, people aren't really arguing against it because it's seen as being in some way invalidating people's experiences or uncaring or unfriendly or just saying, toughen up, princess. And it isn't. That's not what I'm saying. I'm just saying, look, shouldn't we be thinking about intelligently the costs and benefits of this? Undoubtedly, there are some benefits to having a broadened concept of mental ill health, because it means that some people who previously would have suffered in silence and had miserable lives and not sought treatment now will do so. And that's a unalloyed positive thing. But there's also some downsides. There's also, I think it can harm people's identities. I think it can lead people to feel sorry for themselves and feel like victims without agency. I think it can lead to people seeking help of a psychiatric sort when they probably don't need it. I think it leads people to become fragile sometimes. Not necessarily on average, but every time I think we witness this cultural change occurring, we can just sort of give up and say, well, it's happening, and accept it. Or we can say, well, let's think about this critically. What are the costs? What are the benefits? And there are some costs. And I think it's just really important for people to appreciate some of those costs. And one thing I say is, okay, let's say the cat is out of the bag. Let's say this concept has broadened. Let's say we just accept that minor adversities are now traumas. What I then say is, well, how much further should we push it? Is this where we end, or should we now say I stubbed my toe as I walk home and that's a trauma? Why not? We've broadened it so far already. How much further could it go? Because these things will go further. How much further are we prepared for this to go? And I think at this point, in terms of the mental health space, I think we've got an awful long way. And it's not just, I think, because I'm old and crusty. It's because there really is a change where, as you say, it's not just that there's been a really successful destigmatization. It's that we are, I think, increasingly prizing mental ill health, and we are seeing it as being a universal phenomenon. People are now overestimating the prevalence of mental health problems. We ask a random sample, random representative sample, I should say, of US citizens, what proportion of them currently believe they have a mental illness or mental disorder. About 60% of people say they do. And even the epidemiological studies don't give figures that high. People now are seeing this as normative. Is that a good thing? Well, it might be, but we need to think critically about it. And so I think voices that are just reasonable voices that pipe up and say, hold on a minute, let's observe the concept creep. Let's think critically about its costs and benefits. I think those voices are really important.
Yeah. Have you read much of Dr. Alan Francis's work at the APA? So he wrote Saving Normal, I believe. So he's one of those voices that's very skeptical of the medicalization of everyday life. And one of his arguments that I think is worth bringing up now is the following. It's something like, okay, let's say we are going to continue to expand until there's even a higher percentage of people who have a mental illness or a mental health concern. We don't have enough clinicians, let alone enough competent clinicians, at least not here in the States. And I don't think that other countries necessarily have the infrastructure that we do. Not that we're without our problems, because we certainly have that. But one of the things that I've thought deeply about is, okay, well, what is the difference between needing therapy, needing psychotherapy, needing counseling, and being able to benefit from it. I do believe most people can benefit from therapy, depending on their goals or their journey, whatever is going on. I do not think it's fair to say that everyone that I've treated wouldn't have had a good life without it. And I'm thinking about the people who really did show up as really classic textbook manifestations like of a mental health disorder. And so from the social justice perspective, I do think it's very, very tricky, because you very quickly get into this conundrum of, well, you don't want to invalidate anyone, and you certainly, and I don't want anyone listening to this to think, oh, well, maybe I don't have to go, because a consult won't hurt you to go and talk to a therapist and see, if what you're experiencing is something quite severe. But I think about that sometimes, because it's not under the guise of compassion, under the compassion and empathy are often cited as reasons to care about mental health and for everyone to go. But then I think about the scarcity of resources and just the supply and demand. And I wonder, is this actually the most ideal depiction of social justice in this area? I'm not sure.
Yeah, and look, I'm not really focusing on the practical side of this, but I think it's important. And as you say, a lot of people can benefit from therapy and counselling, no doubt about it. You don't need to have APA approved diagnosis in order to benefit from talking to someone who knows something about mental ill health and well-being. But as you say, it's a resourcing issue. If everyone is seeking that, there simply aren't enough people to treat them. And I think it is something different to go to therapy or counselling to seek insight, to seek clarity, to seek better relationships, versus to treat a mental health problem. They're not the same thing. And I guess part of my skepticism is not just the resourcing issue, and not just the fact that it often leads to a sort of maldistribution of resources, because I think more and more people then leave aside those who have more severe problems in favour of those who are more like themselves, who are basically functioning human beings. I think that's a problem. But I'm losing my train of thought a little bit, I'm sorry. I think it's just, as you say, there's a resourcing issue, and we find in Australia, where probably the system isn't massively different from yours, that the data show that people at the milder end of the spectrum don't improve on average. Those on the more severe, this is at least with clinical psychologists, people at the milder end of the spectrum are actually more likely to get worse as a result of treatment than they are to get better, whereas those who are more severe are more likely to improve. So I think there's probably a sort of maldistribution and some people seeking help and, as it were, using resources, which in the Australian context is subsidised by our taxes, and not reliably getting better as a result.
In a way, I'm not totally sure that surprises me, because one of my experiences as a clinician, when someone comes into me complaining of what we would call like problems of living, so there's no overt dysfunction or disorder, but they're struggling in dating because, dating's tough. Intimacy is tough. Finding a partner is tough. And what I find myself doing, and what I think a lot of my colleagues end up doing, is we end up just normalizing their experience, because what can start to happen is if they're suppressing their feelings about how frustrated they are, how disappointed they are, or how they feel rejected and they feel bad about themselves, the emotional suppression is correlated with certain disordered manifestations of some sort of disorder, so something like depression or anxiety or whatever it might be. And I do sometimes wonder, to what extent do I normalize to prevent the onset of a mental health concern? And at what point, to what you just said earlier, is there almost something kind of like indulgent, kind of making it worse? They're thinking about their feelings all the time. I think about this when I help people with their social anxiety. One of the best ways out of social anxiety is you get super curious and thoughtful about other people, and it's back to the big five. There's that correlation between feeling self-conscious and neuroticism. You think about yourself too much, and that's not necessarily a recipe for good mental health. And so from the data, I'm curious, do you have any insight on how to help the typical therapist or the typical person considering therapy figure out where that line is? The data may not exist, but I'm just kind of curious about, because that's something that no one really taught me how to walk that line. I kind of have to intuit it, if you will.
Well, I mean, there is no line. I mean, this is the problem.
Yeah.
There's no bright line separating what counts as psychopathology and what counts as problems in living. If there was, we would have found it by now. Everything's on a continuum. And again, wearing my researcher hat, some of the research that colleagues and I have done on this has shown that to be the case. Everything is on a spectrum. There is no bright line. I guess and I don't really give advice to therapists. I'm a sort of a failed therapist myself. I trained clinically in the US, but didn't stick with it. I just went back to writing tedious papers. But I think, my sense is normalizing is a great strategy. Pushing back on this increasing reach to account for one's problems in living in terms of diagnostic categories. I think that's something best to avoid. And I'm sure more and more clients are coming in for therapy and counselling, framing their problems in diagnostic terms or in sort of pseudo-diagnostic terms like trauma. And putting it into another language is probably more helpful, because I think often putting things into a diagnostic language is counterproductive. It leads people to overestimate how lasting and how biologically based a problem is, makes people pessimistic about their likelihood of recovery, and, as I say, fails to recognize that a certain amount of misery and suffering and dysfunction is entirely normal.
We've been talking about concept creep like it's like every term that starts to broaden has the same implications. And I'm wondering, from your perspective, whether it's just your opinion or whether there's something in the data, if we can differentiate between different terms broadening and what those implications might be. So just as an example, if someone uses the word anxiety interchangeably with nervous, okay, I'm not as concerned about that. Maybe they're being dramatic or comedic, or they're exaggerating, or they just don't know, but I can still pretty easily discern what they mean. When someone uses the term narcissism or trauma to start to encapsulate more of like their everyday experience, or maybe someone's immature or selfish, but now they're also narcissistic, that's when I start to get a little bit concerned, because for me personally, there starts to be a story that gets told, not just about their internal state, but about others and their experience. And I'm wondering to what extent you agree or disagree with that concern. I don't necessarily think that all terms broadening have the same risk for there to be kind of I don't know if maladaptive consequences is the right way to put it, but that's the language I currently have.
Good question. Look, I would expect that different concepts would have different implications when they broaden. There's no claim being made that broadening every single one is equally good or bad. And I share the view. I think partly it depends on what are the implications, what are the connotations of the concept. Anxiety, I think, to me, actually is just a normal emotion. Yes, disorders of anxiety are anxiety disorders, but anxiety actually is a accepted name for a normal human emotion. We all have some of it. If we didn't, we'd probably get into all sorts of trouble by not avoiding things that are bad for us. So yeah, I'm less troubled by the broadening of anxiety. I'm probably more troubled by the fact that it's increasingly talked of in the context of diagnostic labels, because anxiety isn't only a disorder. And we do document in some of our research that the word anxiety and a range of others, which are sort of clinical adjacent, are being more and more talked about in clinical terms as disorders, as diseases, as things which need treatment. But I'm still less troubled by anxiety. But I think, in terms of trauma and narcissism, yeah, I sort of worry about the broadening of those, because I think they do carry certain connotations. To me, the connotation of trauma is something that breaks you or something that shatters you, something that you don't just recover from easily, something where in some way the damage is, if not permanent, at least quite long-lasting. So if you frame your problem as a problem of trauma, you're essentially making a claim about the seriousness and the sort of durability of the harm that you've experienced. So I worry that that gets broadened because it seems to be counter-therapeutic. I suspect it maybe impedes people's recovery, reduces their optimism about overcoming it. It becomes part of their identity. And we know that people who see their traumas as central to their identity don't get better. So to me, that's a real red flag, that concept. Narcissism, I haven't thought deeply about that. I'm sure you've thought much more deeply than I have about that. But it is implying that this particular act of entitled unpleasant behavior you're observing isn't just a one-off, isn't just a state. It's a, mental disorder. It's a part of the person that's sort of baked into who they are that they're not going to recover from. So it's essentially saying you're a write-off. You have a bad personality, probably something that happened to you in your childhood, and there's really not much hope for you. It's really a moralistic judgment masquerading as a diagnostic judgment, I think. So, yeah, I worry about that concept because the connotations of narcissism, to me, are troubling ones in the same way that trauma is, in the same way that maybe anxiety isn't. So, I mean, concept creep has to be evaluated on a case-by-case basis. And if I get anything across in this interview, it's that I'm not saying it's in all respects a good or bad thing, and it very much depends on context. Another example, if you don't mind me getting out of the mental health space a little bit, people often say, when you talk about bullying as a concept that's broadened, when you point out that it initially was only referring to active behavior that was repeated, intentional, downward in a power hierarchy among children, which was the original definition, and it's broadened out to be behavior of a single instance, often acts of omission rather than aggression, that it can be sideways and upwards in hierarchies, and that it occurs in organizations, not just in in playgrounds. Is that a bad thing, Nick? I mean, are you saying that's a terrible thing? And I say, no, it's a quite a good thing. It's good to have this concept of bullying to account for office tyrants. But you have to observe each of those broadenings and be critical about them and judge, is this good or bad in context? So I think, very long-winded answer, I'm sorry. But yes, some concepts you worry more about the creep of than others.
I'm struck by the data you just referred to, that when people label something as, I don't know if it's specific to trauma or just a mental health diagnosis in general, they often, it sounds like they have lower levels of hope, that they feel like they're going to be dealing with this problem for longer. Have they done any studies around the potential performativity of that? Because I could imagine, particularly with psychological pathology, that there is that risk depending on the type of psychoeducation being given, or even the philosophy of trauma. I was educated in the sense that if you're using a correct diagnostic label, that's actually hopeful, because what it means is that you can go through the proper treatment protocols or on the proper medication, and then you can live a symptom-free life for the most part. So it's interesting to hear that some people are experiencing the opposite of that, because I imagine a lot of mental health advocates and therapists and people with brands like myself are putting a lot of this information out there, presumably in good faith. I'm not implying otherwise, but it's interesting to consider that the unintended consequence of that information might be that there's actually increased levels of stigma potentially, or decreased levels of hope.
Yeah, look, I think it could very well have those sort of mixed blessings. There's not a huge amount of work on this. I mean, there is more work looking at not so much diagnostic labeling, but the sort of explanations you give for the problem. So if the problem is given a biomedical explanation or a biogenetic explanation, that generally does lead to more stigma of that kind. It leads to the sense that, well, maybe I can palliate my symptoms with this drug, but nevertheless, I'm always going to have this imbalance. I'm always going to be, at least latently, someone with this disorder. So it can be sort of giving you a kind of optimism, but also a kind of prognostic pessimism is the term that gets used in the literature. So promulgating a certain biomedical etiology does tend, we show in our meta-analyses, to lead people to be blamed less for the problems that they have, but for there to be more pessimism about their ultimate recovery. And I think the same thing goes with diagnostic categories. Yeah, I think it can be hopeful in the sense that finally I have a way of understanding what's going on with me. Finally, I know how I can get the right sort of treatment. And yeah, that's an optimistic message. But also, I mean, we need to be, I think, honest that if you see yourself as a member of a certain category, if a certain noun now describes you, that is likely to be something that you will see is lasting. And in the case of trauma, I mean, trauma is not a diagnosis. It is just, I think, its connotations, I think, are of something which just don't go away by themselves, something that is kind of long-lasting, in a way that the concept of stress isn't. A stress is not something that lasts beyond, the thing that's the event that's challenging you. But a trauma resonates through the ages, I think, is the implication. Look, I think a lot of this stuff, it can go both ways. It's complex. So I'm certainly not saying that this tendency to increasingly see our problems in terms of diagnostic categories or in terms of mental illness is necessarily leading to more sort of pessimistic beliefs about the likelihood of overcoming those problems. But certainly there is some evidence that it can.
I do recall reading a study in grad school. It was looking at stigma in the workplace. And I do remember one of the studies saying exactly what you were just touching on, which is that when you do psychoeducation around the different brain structures or hormonal profiles of someone with bipolar or major depression or whatever it might be, that it actually created this narrative within that office or within that test group in which, oh, that person actually can't stop being like this, and it actually encouraged those punishment behaviors versus when you educate someone about diabetes or maybe someone's a paraplegic or whatever it might be, it actually elicits those helping behaviors as well. Do you think it's based on, because it sounds like this has been replicated in different settings, does that kind of stigma, if that's the best way to articulate it, is it as simple as that? It's, well, we look at physical illnesses differently and mental illnesses are so stigmatized that even when we have a biological or chemical component, we're just going to use it to double down? Or do you think one could also, as I'm just thinking about this out loud, one could also argue that when you introduce the biological component, it becomes too complex. And so cognitively, people just start to react. They don't even want to deal, and so it's much better to just other the out group in question.
Yeah, I don't know. Look, I think the research does suggest that if you endorse a more biogenetic explanation, you do tend to see mixed blessings for trauma, for stigma. You do tend to see the person as being less in control of their problems, and the benefit of that is you can't blame them as much. You can't hold people morally responsible for overcoming their problems if it's out of their control, if it's part of their wiring or their brain chemistry. And that's a good thing. Blaming people less is a good thing. And look, this is what motivated lots of anti-stigma campaigns over the ages. If only we could see mental illness as the same as diabetes or cancer, then stigma would evaporate. Unfortunately, there's the downside. The downside is if you think the person doesn't have control over their problems, if you think it's due to their bad brain or bad wiring, bad biology, then you see them as being unpredictable, you see them as being dangerous, and you see them as being less likely to be able to overcome their problems. That same prognostic pessimism idea I just put across. This is very well established. Great work by Matt Leibovitz and others in the US. We've done some of this work ourselves. So, it's a double-edged sword, but I think the idea that if we simply accept biomedical explanations for mental health problems, that stigma goes away has been comprehensively falsified. And as you say, yeah, it is mentally complex. I think that we are all dualists. We tend to flip between it's either the biology or it's the mind. It's either something wrong with your brain or it's the trauma that happened. And getting people to recognise, well, it's a bit of all of these things coming together in complex ways. That is cognitively demanding.
Mm-hmm. It's really, really interesting to consider the broader effect, particularly on social media, that a lot of the psychoeducation around the potential biological underpinnings or consequences of trauma or mental illness or whatever it might be are doing to people and to stigma. I agree there are obviously a lot of benefits. People are more open, they're more likely to get help. Maybe some people are even feeling more empowered, but it is a little bit scary to consider that there's also this the opposite is happening in certain cases, particularly around trauma. I see content, very popular content, by the way, all the time talking about the effect that the traumatic stress has on your different brain regions, on your genetic expression, epigenetic expression. And when you start getting into epigenetics, that's probably one of the more political fields, at least from my observation. People start to kind of take those findings, a lot of which are still very early and premature, and absolutely run with them. But it is interesting to consider how we might better make content and do messaging about these things, keeping everything you just said in mind. Do you have any suggestions for any content creators, or even just myself listening, if I want to go and make a post about how, so we know that PTSD can affect, like the left Wernicke's area, like the language center of the brain. And that's why it can be so difficult for people to put their trauma narrative into words. And that's one of the reasons why narrative exposure therapy, or some variation thereof, is so effective with trauma. You're kind of turning on these regions again. Is there something that is anything coming to mind that people can do to maybe guard against the stigmatizing effects or the disempowering effects?
I'm not sure exactly what they can do, except to sort of point out that just because something has some sort of brain manifestation doesn't mean it's unchangeable. I mean, there is still this view in people's minds, despite people talking endlessly about plasticity, that when something is part of your biology, it's part of who you are forever. I mean, the human mind essentializes things. If something is seen as being part of your body, people infer that it is lasting. I think so. One thing you can do is just be clear that this may well be true. It may be the case that as a result of adversities you've experienced or traumas you've experienced, certain aspects of your brain function may change, but that doesn't mean they change forever. It doesn't mean that therapy that doesn't directly target brain processes can be improving things, can be overcoming these problems. Fighting against this general tendency to think that biological stuff is unchangeable stuff is part of the issue. I think the issue around psychoeducation is not so much about explanation. It's more about how do you conceptualize what you have. Do you have a mental health problem? Forget about how it's caused. I mean, of course, people don't forget. They want to know. They want an explanation of why they have what they have. But what is the most fruitful way to think about the nature of your problem? And I think the increasing use of diagnostic concepts is problematic because, yes, in some cases it can lead you to accurately identify the nature of the problems you're experiencing and getting appropriate help for that, which is good. But also, as the terrific British psychologist Lucy Folks has been arguing recently, I'm not sure you've come across her work, it can actually lead people to misperceive the nature of the problems they have, identify with problems they don't really have, and that can have self-fulfilling effects. If you self-diagnose with anxiety, that can lead you to avoid things that probably would be better for you to expose yourself to. It can lead to a kind of vicious cycle of deepening and embedding the problems you have, and of course making them central to who you think you are, changing your identity. So I think we've really got to be a bit more careful in content, in trying to just work against people's tendencies to adopt diagnosis-based identities.
Absolutely. Your diagnosis is not your destiny is one of the taglines I've been putting out there. Like I said, it should be, for anyone listening, it should be a hopeful thing. I had a wonderful conversation with Dr. Carleen McMillan, and we were talking about how even 10, 20 years ago, the diagnosis of borderline personality disorder was just kind of seen as, well, this is what you have now, bummer for you. But now we know, at least as far as personality disorders go, it's one of the most hopeful diagnoses you can get, because if you're committed to treatment and you go and do the DBT and the mentalization-based therapy and all the other things, and you get a clinician that really knows what they're talking about, you'll be in remission within 2 years. Which is wonderful news for anyone that has struggled with that diagnosis. Often the etiology, which is often based in trauma or something difficult in the past. So
No doubt. And again, I was undergoing training in the sort of 90s, and it was a much more pessimistic narrative at that time about things. And you were basically counselled, as a therapist, to sort of beware and not expect much progress, except maybe aging would take care of it in the long term. So I think the stories we tell about these conditions really makes a huge difference to how we approach them as professionals, but also how people see themselves. And people's self-conceptions really matter in this business, really matter, how they see their own level of hopefulness, and whether they see their identity as something that's going to define them forever after, or whether it's just some transient issues they're having that could be resolved.
Yeah, absolutely. Something I'm really enjoying about you, and not just your philosophy, but also your personality, and something that I'm present to right now, is really the importance of humility as we go about collectively trying to figure out some of these problems and where the line really is. Because like you said, it's often very, very context dependent. It's often case by case dependent. And a lot of these terms are not necessarily super objective and measurable. A lot of them are philosophical. And it's okay to have those philosophical differences, if I'm understanding you correctly. Is that a fair takeaway from our conversation?
Yeah, and again, I think these things are measurable, just imperfectly. We're not in a business where you can measure things with perfect precision like you could in sort of physics or chemistry. That doesn't mean they're illusions. And I think the issue is not so much that everything is subjective and up for grabs. It's more that we can measure these things reasonably well, but there's always an ambiguity about the severity at which something becomes a real problem. And I think part of what concept creep does, at least what I call the vertical form of concept creep, which is the tendency for terms to be used at lower and lower levels of severity to refer to less severe problems, is knowing sort of where to draw that line. So I think we can measure degrees of depression or degrees of OCD or degrees of psychosis pretty well. The challenge, I think there's huge amounts of research on this. The challenge is people disagree at what point disorder starts and normality ends. Probably not the best way to say that, and that to me is the problem. Not so much that everything's subjective and woolly. It's just that there is inbuilt intrinsic ambiguity in this space. But I think you can make an argument in many cases that the pendulum has swung too far downwards, and that people are, I think, identifying things as being illnesses or disorders when they're really not quite meeting what is a reasonable threshold.
Well, so it's something I've thought about. Let me throw out a theory to you. I wonder what you might do with it. I do think there is a cultural variable, and by culture, I don't necessarily mean, I don't necessarily mean like the subculture of which you live. It might not be the perfect word for it. Let me give you an example. So let's say you have ADHD, moderate severity. And let's say you were born in a family with a good amount of resources, and so you get to work a few part-time jobs and live on your savings, and you get that variety, and you get to bounce from thing to thing. And for your brain, for your ADHD brain, that variety is really important to you, and that's what you like. Take someone with ADHD and put them in a different family with less resources, or maybe even a different country where it's more being like industrially developed. And really what you need to do to be successful is you need to have a very expensive, technical, boring, repetitive job. Your mental health is not necessarily going to excel in the latter. I've sometimes thought about this, and I've wondered, well, how do we, I thought about this in my content. I was like, how do we make it clear that they can both have ADHD and they can both objectively have ADHD? Like, we can measure that, to your point, but how do we make it clear that this is really only going to be a problem? It's going to cause some sort of dysfunction potentially for the latter example. And I think about that sometimes because I think about, well, that predicts, resiliency in terms of stress response, and with all sorts of different mental pathology. It depends on how well resourced you are, how well set up you are. And you could also think of it in terms of personality too, right? Being a really open-minded liberal person in certain countries is going to, in a city, let's say, here in New York, this is where I'm based, wonderful. It'll be absolutely wonderful for you. You drop me in some other town in America or some other country or city around the world, my openness is not going to serve me very well. It's going to cause some sort of dysfunction. So I wonder if that is part of where to find the line, is to kind of consider that broader cultural context and whether or not the match is going to be adaptive or whether it's going to cause a lot of social disruption for you.
Yeah, I mean, look, I'm a social psychologist. I think social context matters enormously. But look, I think this is actually built into how we're supposed to be diagnosing mental health problems. It's meant to be when they're creating, significant dysfunction. And that's always going to be in context. So maybe your first person with ADHD actually doesn't have ADHD. Maybe they have the symptoms, but if they don't actually, if it isn't substantially interfering with their life, work, love, whatever else, then they're a person who might have been ADHD had they been in a less hospitable environment for them. But maybe they're just someone who's got a distinctive temperament or personality which doesn't meet criteria. I'll put to you the idea that I think a lot of people, when they're making diagnostic judgments, just everyday people, not professionals necessarily, are focusing on symptoms. They're not focusing on dysfunction. But when you're making a diagnosis, you're meant to be not just matching a person to a profile of symptoms, you're meant to be evaluating, is it substantially affecting their life? And we don't do that enough, I think. And I think part of what goes on with this rampant, over self-diagnosis among some people, and our research shows it tends to be younger people and more liberal people, is that they're knowledgeable about symptoms, but they over-apply the diagnostic label to themselves because they don't adequately consider the level of impairment or dysfunction. So I completely accept what you're saying, that these things are contextual, that they depend on environment. Of course they do. They're meant to be interactions between your temperament, your biology, your environment. But I think often people neglect to consider that impairment aspect, which is often much more important than symptoms.
Yeah, absolutely. So if you take the ADHD example, someone could say, oh, someone who's what are stereotypes about people with ADHD? Maybe they're a little bit of a space cadet and ditzy and disorganized and creative and whatever it is. Well, if that's okay, if they have a career that rewards that, or if they're resourced where that doesn't actually impact them, well, then maybe they don't actually have ADHD. Maybe they're just kind of creative and disorganized and spacey and a little bit distractible. But the minute it actually starts impairing, to your point, that's actually when we can start to tap into the more clinical way of speaking about things.
I think so. I mean, I think that to me is almost self-evident, but I think a lot of people don't grab that, don't really appreciate that idea. And I think a lot of people self-diagnose, and I think, maybe getting myself in trouble, this does happen a lot with ADHD, where people self-describe in terms of being a little bit careless or not good with detail and creative, which was never a part of the ADHD diagnosis, by the way. It's become part of the concept creep of what counts as it. And look, if it's functioning well, if it's allowing them to have this hyper-focus and this creativity and have an interesting life, even if they tend not to, they forget appointments and stuff like that, they don't really have ADHD to me, unless it's a clinically significant impairment. So, I think self-diagnosis often occurs in the absence of genuine, warranted diagnosis.
Well, I think that I keep going back to the impairment criteria when I, in my content, try to contextualize these different terms for people, because it is, I don't know if it's the best place to plant my flag in the sand, but it's a place, and it's a place that has worked historically. Different clinicians would probably disagree with what we're saying, because they would say, I think it's the Psychodynamic Diagnostic Manual has a line which says, well, the absence of heart-related symptoms does not mean there's not a cardiac condition, and so let's actually be a little bit more curious. And I think there's something to that school of thought as well. But when it comes to picking the label and the implications for identity, as you're talking about, I think that it's probably worth a second consideration. At least that's my current thinking on it.
That sounds good to me. Yeah, and look, I think the cardiac condition example, I should say, is a little bit different in that it's saying you may be manifesting in symptoms, but there is a very high likelihood that symptoms will occur in the future. And in psychology, we're just not that good at predicting risk. You can't say, you're currently asymptomatic, but you've got X disorder, because we can predict with high likelihood that you're your mind will give out in 2 years if you're on the treadmill. I mean, we just don't really have that kind of level of precision. Our diagnoses are not about risk; they're about current reality of dysfunction and impairment.
Well, as much as I could continue talking to you, I've been having just a lovely time in this conversation, and so much I want to follow up about. We do have to wrap up here shortly. For anyone listening, is there anything you want to leave them with in terms of just any of the stuff we talked about or anything that we didn't cover?
Not really. I would just encourage them to look up my work and sort of see some of the science on this. I think it's great that there are people who are presenting in intelligent, accessible ways, like yourself, Joe. I think I really enjoyed this conversation. There's an increasing amount of solid empirical work on this as well, and anyone curious, it's not hard to find it. And drop me a line if you'd like some.
Definitely. How can people find your work and reach out to you?
Well, a lot of it's available on my ResearchGate page. ResearchGate's just a website where people deposit their empirical work, their papers. It's very easy to find it or to request it. And I've written some more accessible pieces. It's not all numbers and graphs, but people who love numbers and graphs, there's a lot of that there as well. And we do a few things. We do some work where we actually do look at the evolution of concepts of mental health and the like over 50-year periods. We also do some work looking at experimentally looking at the implications of self-diagnosis. There's a lot of stuff out there. I'm not the only person doing it, but I just hope the listeners got the general gist, and I think this work is just really, that you're doing is really important.
Yeah, I appreciate it. I appreciate you taking the time to talk to me. I feel like I learned a lot, and I can't wait to figure out the messaging for some of these things to really broadcast it. For those of you who are still watching, you'll be able to watch the highlights on my social media. Nick, are you on social media as well?
No,
Can they find you anywhere? All right, fair enough. I understand. I will be posting the highlights, and you can like and subscribe Therapy versus the World on Spotify, on the podcast app, wherever, on YouTube, wherever you get your podcasts. And remember that Therapy versus the World is early and ad-free only on Luminary.